commemorate the World Kidney Day, which was actually on last month, and because of logistic reasons, we thought we would have the meeting today. And for this, we have selected a topic which is pertinent for all pediatricians, practicing pediatricians, because urinary tract infection is a condition that we all come across very often, and we all have queries on how to manage it once in a while, because all UTIs don't present to us, or we cannot manage them as given in the textbook. So I would like to thank our speaker, Dr. Susan Uthup, for agreeing to give her talk on this important subject. Welcome, ma'am. There's no need to welcome people in our home, but still it is my duty to welcome Riya sir, President IAP Kerala State, and Dr. Gopi Mohan, Secretary IAP Kerala State, to this meeting. I also welcome all my seniors. I can see Purushothaman sir, Rajagopalan sir, many seniors already attending. And I would like to welcome you all the attendees. I hope you will be benefited by today's session. Thank you.
May I now request Dr. Riyaz sir, President IAP Kerala, to give the presidential address.
Respected President of the IAP Nephrology Chapter, Dr. Radhika, my teacher, Susan Madam, senior teachers in the group, Purushothaman sir, and all the senior leaders. So this year we are conducting webinars on each important day so that we can update our knowledge on that particular area. So being very busy in March, because March had many days. We had the Down syndrome day, the TB day, and so many things. So we were not able to conduct it on the proper day. But Susan Madam kindly agreed it to have it on the 1st of April. So it is always music to hear Madam's lectures because of its clarity. And I think urinary tract infection guidelines are changing so fast, and there are different guidelines from different groups. And it is always a problem for the pediatrician to get updated. So today I think we will have all the answers from Madam. I wish happy learning to everyone, and I congratulate the nephrology chapter for organizing this. Thank you.
May now request Dr. Gopi Mohan sir, Secretary IAP Kerala, for the felicitations. Dr. Gopi Mohan sir.
Gopi, എനിക്ക് തോന്നുന്നു ഹോസ്പിറ്റലാണെന്ന് തോന്നുന്നു കേട്ടോ. ഗോപി അവസാനം കമന്റ്സ് പറഞ്ഞോളും. We will go to the meeting. Okay.
May I now request Dr. Christy Catherine Thomas, Assistant Professor of Pediatric Nephrology, SAT Trivandrum, to introduce the speaker.
Hello. Dr. Manjusha, am I audible?
Yes, you are audible.
Okay. Good evening, everyone. As you all know, Dr. Susan Uthup doesn't need any introduction, but I would consider myself lucky to introduce my own teacher, Dr. Susan Uthup, Professor and Head of Department of Pediatric Nephrology, SIT Hospital, Government Medical College, Thiruvananthapuram. Of course, she is a visionary leader in the field of pediatric nephrology. Madam has a big role in establishing and developing the area of pediatric nephrology. Had established the first pediatric nephrology department in Kerala, and I think this is the first in the country. Even though a resident of she did her MBBS from Kottayam Medical College, MD Pediatrics near Mumbai, young from Government Medical College. She is an astute clinician and patient fellow. She loves teaching, and she is a great teacher. Her students will
others.
To her teaching many guidelines as part of ISBN 2. She's an editor and author of many books and chapters in gastroenterology and nephrology. She is
ചേച്ചിയോട് പറഞ്ഞിട്ടുണ്ട്.
stations of nephrology. Even she was sick during the COVID times. Currently, she is the president of Trivandrum Nephrology. She has many laurels to her credit. It may take at least 30 minutes to describe all. She has a gold medal in MBBS to many awards and appreciations to her credit. So we are privileged to have her as a speaker on the topic UTI. It's a straightforward topic that we all will think, but it is deceptively simple topic. Welcome, madam.
Susan, ma'am. Hello.
Hello, can you hear me?
Yes, ma'am. Yes.
Thank you, Christy, for that introduction. And I'm really honored to have you actually introducing me to this gathering, which is actually the home ground for me. And I congratulate the Pediatric Nephrology chapter of IAP Kerala as well as IAP for giving this opportunity to me to talk on a very common problem in children, that is urinary tract infection. And
ഇല്ലില്ല മാഡം പോയിട്ടില്ല, പക്ഷെ മാഡം ഇടയ്ക്കിടയ്ക്ക് ലീവ് വന്നു ഇതൊക്കെ ബാക്കിയുള്ളവരൊക്കെ ഈ 2 ആഴ്ച പോകണ്ട, അടുത്ത ആഴ്ച പോവാന്ന്.
Everybody can mute, it will be better.
മാഡം ലീവാ. സാറ് പറഞ്ഞു തൽക്കാലം ഇപ്പൊ പരീക്ഷാർത്ഥികൾ 2 പേരെയും വിട്ടിട്ടില്ല സാറ്, അവർക്ക് ലീവ് തുടങ്ങാനായി. അവര് പോകുന്നതിന് മുന്നേ ലീവ് എടുക്കാനുള്ള എടുത്തോന്ന് പറഞ്ഞു സാർ.
Shall we continue?
ഹോസ്റ്റ് എല്ലാവരും മ്യൂട്ട് ചെയ്യിച്ചേ. വേഗം
Shall we continue? Riyaz, can we continue? Can you hear me?
Yes, madam. Yes, madam. Please continue.
But
Okay,
others
so-
are speaking.
So this is a very common problem that everybody is facing, that is urinary tract infection, and most often we see children with UTI getting undertreated as well as overtreated. So there is definitely it is important for us to discuss, and the new ISPN 2023, it is not new, it is almost 2 years, guidelines have come, and so that guideline has actually made things much simpler and clearer for us to follow. So let us now see after a brief introduction on urinary tract infection, we will go to the guidelines. So we all know that urinary tract infection means there is growth of pathogenic microorganism within the urinary tract. And any child with fever, especially in infancy, when there are no focus that is clear to you, you will be thinking of UTI as a cause, and we will be going after the evaluation to diagnose UTI and treat UTI. And it can be that UTI can be actually divided into either upper tract UTI, that is pyelonephritis, and the lower tract UTI, that is cystitis. But of course, that differentiation will not be very clear in small children. And 3 to 15% of children with first UTI can show parenchymal scarring within 1 to 2 years of their first UTI, and this will be a risk of acquired CKD in the future. And the UTI rate is actually the highest in the first year of life, and girls actually outnumber boys in the incidence of UTI. The UTI is more in uncircumcised boys, and beyond infancy as well as prepubertal, it is more common in girls. And recurrence of UTI occurs in a significant proportion of children in the first 6 to 12 months after the first episode of UTI. And the recurrent UTI, now we all know that the underlying problem can be a kakut, that is congenital abnormality of kidney and urinary tract, or bowel bladder dysfunction. Bowel bladder dysfunction is actually gaining lot of importance in the era when the lifestyle related problems are there affecting the pediatric age group also. And we all know that common organism causing UTI is E. coli. And when the organism is not E. coli, we actually have to be really looking at whether there are underlying problems in the urinary system. So what is why UTI is a difficult problem to diagnose? Sometimes we will be underdiagnosing, sometimes we will be overdiagnosing because it is difficult to recognize. And urine culture still remains the gold standard for UTI diagnosis. And urine collection is difficult in children, a proper sample that is, and the interpretation is not easy. Most often the diagnosis is not confirmed because the child may be having the symptoms, urine may be having pyuria, but bacteriuria may not be documented, and then you are actually totally getting confused. And we have to understand that febrile UTI with a culture positivity of a specific organism can be a marker of Kakut. And almost 1/3 of children who have UTI will have VUR. And now we know that UTI as a cause for VUR and VUR as a cause of end-stage kidney disease due to recurrent UTI is becoming less and less common. And so this UTI is actually a story of controversies. An 8-month-old female baby presented to the emergency room with fever of 3 days, persistent vomiting and irritability. Child is febrile and toxic, and there are no localizing signs. So when there is no localizing sign, then you have to, and especially if the fever is more than 48 hours and high-grade fever and a toxic child, urinary tract infection should be one at the top of your list for causes. So we will be having some pertinent questions answered along my presentation. So the first question is when to suspect UTI. So the clinical suspicion is most important. Symptoms and signs can be non-specific, especially in infancy, but fever is most common. And in less than 3 months of age, it is really vague symptoms. That is, baby may be having lethargy, irritability, refusal to feed. It may be a diarrhea that is the presenting symptoms. E. coli UTIs can be associated with jaundice. The baby may be having low urine output or a high urine output of polyuria. But foul-smelling urine, dribbling, and urinary symptoms in a child who is actually having failure to thrive, we should be really thinking of UTI as the underlying problem and Kakut also to be ruled out. And in older children, more than 5 years, abdominal pain, back pain, new onset incontinence, that is another important symptom. Dysuria and frequency may be the symptom. Adolescent girls, actually, it will be the cystitis urethritis complex, which is most often seen with dysuria, urgency, that is lower urinary tract, irritative voiding symptoms, cloudy urine, and hematuria. So also the past history is important, especially the baby is having an antenatal. Nowadays, ultrasound has become so universal. Antenatally diagnosed renal abnormality, previous UTI or even undiagnosed febrile illness, VUR, chronic urinary symptoms like incontinence, poor stream, frequency, urgency, and holding maneuvers. Bowel bladder dysfunction as an underlying problem is quite often missed unless you really probe the history properly and look for it. And chronic constipation is another history that is to be given importance. And then family history also is important, as we know that VUR can run in families. So our suspicion of UTI is now over. And the next is how to diagnose UTI. So we have to look at the urine in a symptomatic child and with high-grade fever or other urinary symptoms. And when you look at the urine specimen, it will be dark-colored or cloudy. It may be foul-smelling. The freshly voided urine, actually, it is having a good aromatic smell. Only when the bacteria is there or bacteria, you keep the urine for a long time, it becomes foul-smelling. So smell of the urine is important. You look under the microscope, if you see that viable bacteria are there in a freshly voided sample, that is bacteriuria is there, as well as the pus cells which are there in the number is more than 5 in a centrifuge sample and more than 10 in a non-centrifuge sample, you call it as pyuria. So pyuria and bacteriuria under the microscope, if you see, but current emphasis is more on is given, especially in the current guideline on urine dipstick for making it is a presumptive diagnosis of UTI, and that is leukocyte esterase and nitrite. If it is positive in combination, it is a first-line screening test for UTI. And of course, we have to confirm by doing a urine culture. And the next question is how we will be having the urine sample taken. Collecting a good urine sample is the most a most difficult problem in the diagnosis of urinary tract infection. So it can be a clean catch midstream urine, or it can be a catheterized specimen, or it can be a suprapubic aspiration. So the clean catch midstream urine can be taken in a child who is conscious and in a little older age group. We can take the urine. You have to clear clean the area and then take the midstream sample. And then it is the benefit is it is non-invasive and minimally contaminated. But it is important. You have to give a good advice to the parent. The labia should be separated in a girl, as well as the foreskin should be retracted in a boy. And the area should be cleaned with not with any antiseptic solution, but with water. And then the midstream sample is to be collected. And the urethral catheterization should be an in and out catheterization. And it has to be a non-touch clean technique. And it is actually in a pre-continent children or an infant or a small baby. If you can actually have this specimen, it is less, it is actually, if it is done properly, it is not as invasive as the suprapubic aspiration. And so suprapubic aspiration, sometimes you have to resort to, if you are totally in doubt and you are not having the proper specimen collected, in such cases, you can have the suprapubic aspiration done, and that can be that will be giving a very good sample for urine culture. So always remember that significant growth of a single uropathogen in the urine culture in the appropriate clinical context is important. So that is very important. It has to be an appropriate clinical context. Just doing a urine culture regularly for follow-up is not to be practiced. And so what is significant bacteriuria? The current guideline is telling the suprapubic aspiration, if it is more than or equal to 10 raised to 3, and a catheterized specimen if it is more than or equal to 10 raised to 4, and the clean cat specimen also, it is 10 raised to 4 is also considered significant. Previously, we were taking it as 10 raised to 5. So the threshold has come down in the present guideline, because there are many studies which suggest that if we keep the threshold high, we may be missing some of the UTIs. So these are certain definitions that are to be there. Leukocyturia I have already discussed. Bacteriuria is actually a freshly voided, uncentrifuged urine sample if it is having one or more bacteria per oil immersion field. That is considered as bacteriuria and significant. And acute pyelonephritis is the kidney parenchyma is inflamed and infected. And cystitis if it is localized to the bladder. And recurrent urinary tract infection is 2 episodes of UTI occurring during any time period in childhood is considered as recurrent UTI. And febrile UTI is when the fever is more than 38 degrees centigrade with positive urine culture, that is presence of the significant colony count of a single uropathogen. And VUR is primary VUR when you have got the MCU showing that the urine is going back from the bladder to the ureter in the absence of an obstructive uropathy or a bowel bladder or a neurogenic bladder sphincter dysfunction. And low-grade VUR is, we all know it is grade 1 and 2, and high-grade VUR is grade 3 and 5, both on an MCU. And reflex nephropathy is abnormality in the renal cortex associated with primary VUR, which can be actually congenital renal dysplasia. That is, the child is having VUR but diagnosed, but there are no definite history of UTI. And this occurs most often in males, and that is congenital renal dysplasia. And acquired scarring usually is seen in VUR in females. So categorization of UTI, we have already discussed. The upper one will be presenting with symptoms of fever, anorexia, vomiting, lethargy, malaise, abdominal pain. That is more of systemic symptoms, whereas lower UTI will be more of irritative, voiding symptoms and abdominal pain. And this the morbidity due to infection will be there in cystitis urethritis complex also. So we have presented a child. That child, UTI is a possible diagnosis, but how to diagnose UTI? So the suspicion along with both of the following criteria, that is urinalysis suggesting pyuria and or bacteriuria, and urine culture growing a single uropathogen at least 50,000 colony forming units per ml. And his urinalysis showed plenty of pus cells and RBCs. And so a urine culture was performed. And then the next question is, so once we have collected the sample, we have got the urine culture positive, how the infection should be treated. So treating the infection is, the aim is to eliminate the infection, eliminate the bacteria, and small child. So prevention of urosepsis is important and relieving the acute symptoms. And then the long term is preventing the recurrence and the complications. So when will you hospitalize a child and when will you give parenteral therapy? If the baby is less than 2 months, you cannot go for oral therapy. Then clinically urosepsis is there. That is, the child is toxic, hypotension, poor capillary refill, to diagnose sepsis, or vomiting and child cannot tolerate oral medications, an immunocompromised child. And then you are not sure of the outpatient follow-up. In such conditions, if the child is febrile and toxic, it is better to put the child in the hospital and treat with IV antibiotics. And the last is the failure to respond to oral therapy. So we have already seen that oral is as effective as parenteral, but the initiation of antibiotics should be within 40 to 72 hours of fever. And the IV antibiotic indication we have already discussed. And then the next question is, what is the choice of antibiotic that we have to start? So third generation cephalosporin or amoxiclav is the initial empirical therapy for UTI, suspected febrile UTI in children. And if it is a cystitis urethritis complex, you can go for first generation cephalosporin like cephalexin, cefadroxil, or you can give amoxiclav. And usually for the pyelonephritis, now the recommendation is 7 to 10 days of antibiotics, whereas for lower UTI, it is even 3 to 5 days of antibiotics is also deemed okay, especially in an adolescent time. But we usually go for 5 to 7 days. And so these are the antibiotics that are usually given, which are the empirical antibiotics. We all know these antibiotics and their doses. But we have to look at and remember about some red flag signs during a UTI, which will suggest a structural abnormality, that is atypical UTI and complicated UTI, non-E. coli UTIs, seriously unwell, child is having sepsis, there is an AKI, urine flow is poor, there is a palpable abdominal mass, that is rhinomegaly, or the bladder is palpable, and failure to respond to appropriate antibiotic within 48 hours. So then this coming to the physical examination, always look for the neurogenic bladder sphincter dysfunction. The signs may be patulous anus, neurological deficit in the lower limbs, urinary incontinence, previous surgery of the urinary tract, and anorectal malformation. We have to understand that high ARM, 30% of the cases can be associated with a neurogenic bladder sphincter dysfunction and myelomeningocele. Then local problems may be sometimes missed. Physical examination is very important. I still remember a doctor's child being brought to me after episodes of recurrent UTI and getting evaluated in multiple places. And on examination, this girl child was having vulval synechia. So unless you strip the child and do a physical examination, you may be missing a tight phimosis or vulval synechia. So it is important. And so the next question is, after we have reasonably treated the urinary tract infection, what are the radiological science imaging that is to be done? So is your routine ultrasound examination necessary for a first time uncomplicated UTI? So this ultrasound sound is now universally available, and any child, you have to do an imaging of the urinary tract if the child has febrile UTI. It may not be an acute ultrasound that is done while the child is in the hospital, if the child is responding within 48 hours to antibiotic. But even after discharge, at some point of time, one ultrasound scan is important in uncomplicated UTI. But emergency ultrasound examination is to be considered if the child is having atypical UTI with atypical microorganism, non-E. coli UTI, child is seriously ill with UTI in the last 48 hours, and scan should be done and scan within the first 48 hours if it is serious illness, and renal failure, AKI episodes are there. Anomaly of the system is suspected as evidenced by a poor stream or a palpable abdominal mass. Then failure to respond within 48 hours and recurrent UTI, we have to do ultrasound while the child is in the hospital. So the next is we have to decide judiciously whether we should evaluate all. But lot of MCUs have been done, lot of this X-ray exposures have been given to children in the past, whether we are actually justified in doing VCUG routinely after the first episode of UTI. But we have to understand that we should not be making blanket statements that no MCU, no. that we have to judiciously select who will require to be examined by an MCU. So if this atypical signs, red flag signs are there in the first UTI, which is already discussed with you, and recurrent UTI, and if there is a voiding dysfunction that is there, in that case, we have to go ahead with voiding cystourethropy. And DMSA in the acute phase is now not indicated. We will come to that later. And so atypical and complex clinical circumstances, ultrasound showing a suspicious of obstructive uropathy or a high-grade VUR. VUR can be missed completely on an ultrasound because only MCU will be able to pick up the VUR as well as to grade the VUR. Grading of VUR is very important in deciding on further management. Then recurrent UTI, we all know, it has to be evaluated in toto. And so the current ISPN guideline is ultrasound scan indicated in all patients. It is non-invasive and no radiation exposure, and dynamic images can be obtained. MCU in abnormal ultrasound scan, patient less than 2 years with non-E. coli UTI and patient with recurrent UTI. And this will help to find out whether the patient is having some presence of VUR or other Kakut like posterior urethral valve is there. Then late or neurogenic bladder sphincter dysfunction, of course. And DMSA scintigraphy, we should be done in all children with recurrent UTI, and it should be planned 4 to 6 months later after the last episode of UTI, that is the index episode that you are treating, and it is a gold standard for detecting the kidney scars. So we have done the radiological test, and now the last question is how the affected child is followed up. So this 8-month-old female child, after 48 hours of IV antibiotic, she was febrile and she was discharged to complete the oral course. And renal ultrasound was reportedly normal, but considering the age of the child being less than 2 years and febrile UTI, the baby was subjected to a BCUG and a grade 2 VUR was on the left side was diagnosed. So now this child is having a low grade VUR. How we should be following up, how we should be treating, and what is the long-term impact of this. So when we look at the traditional conceptual model, that was the past, all the senior people who are sitting here will be understanding how much we were actually bombarding on this paradigm and on this conceptual model, and we were treating, we don't know whether we were over treating these children. And the VUR grading is like this, and this is grade 1 and 2, which is low grade VUR, where the system is not dilated. There is no dilatation, but the urine is going up to the kidney in the grade 3, stage grade 2. Whereas grade 3 onwards, there is progressively more and more dilatation, and the grade 5 VUR, there is loss of actually papillary impressions and gross ureteric dilatations will be there. And this sort of a kidney is actually more common in boys, infants, male infants, and will be usually associated with renal dysplasia. And renal dysplasia is the cause for this progressive kidney dysfunction. And in such cases, it is not the UTI episode, which is the reason for this renal dysfunction as the time passes. So there is a paradigm shift in the understanding that has resulted in change in the practices. And we have now come to the point that long-term consequences are less likely. Hypertension, proteinuria, and ESKD from VUR and UTI is actually not UTI, but this presence of renal dysplasia that is already there, and this child without UTI also would have progressed. So what is the real significance? And so reflex nephropathy, VUR, is it a chicken and egg situation? And how much we should be thinking about the risk of recurrence and acute febrile illness by UTI, and should we be giving them all antibiotics? Whom to be given antibiotic prophylaxis? How long to give antibiotic prophylaxis? Is it to be continued to adolescence and even into the adulthood? Is surgical correction is required in all cases? These are certain questions that were looming large in the population, in the doctor population or pediatric forum in the past few years. And so there is a significant change in the evaluation that is there, especially in the current era where a lot of studies have come out which are bombarding on the antibiotic resistance induced by the uroprophylaxis, and that is increasing globally, highest in the resource limited settings, and which is actually increasing the healthcare cost. And so whether we have to identify and treat the bacteriuria in the immediately after it sets in a symptomatic child, or whether we have to treat or do periodic urine cultures, and that is often quite a common practice among the pediatric forums nowadays. We do periodic follow-up of VUR children and do urine analysis as well as urine culture. The one important point that is to be made at this juncture is never do follow-up urine cultures. The child will be asymptomatic, and asymptomatic bacteriuria doesn't require treatment at this point. That is the current guideline. So don't just do urine culture in children who are not having symptoms. So regular follow-up urine cultures is not required even in children who are on uroprophylaxis or not on uroprophylaxis. Just don't do urine analysis. You can do if the child is symptomatic with pyuria, then we can do the urine culture. So the uroprophylaxis, the current concepts is actually a very simplified approach. The guidelines suggest against using antibiotic prophylaxis in the prevention of UTI in children with normal urinary tract and absence of bowel bladder dysfunction. That is the first point. There is no need for antibiotic prophylaxis in a child who is having normal urinary tract and no bowel bladder dysfunction. Second point is, this guideline suggests using antibiotic prophylaxis for preventing recurrent UTI in patients with high-grade VUR, that is grade 3 to 5 VUR. Then the question we will be asking is how long to continue and when we can stop it. So, if the child is having febrile UTI and bowel bladder dysfunction, even if the MCU is normal, there is no VUR, in that case, also you have to give uroprophylaxis. So two children we are identifying now. One is with a high-grade VUR with UTI, febrile recurrent UTI, and the second is a baby with febrile UTI and bowel bladder dysfunction. Even without VUR, we have to give uroprophylaxis. Then if the child is baby is diagnosed to have antenatally detected hydronephrosis, and we are waiting for evaluation to be completed. When we see an antenatally detected hydronephrosis, two possibilities we will be thinking about. One is VUR and other is an obstructive uropathy. So we have to get the MCU. We have to decide on MCU based on the severity of the detected this hydronephrosis. But there is no need to give prophylactic UTI prophylaxis in such babies in the absence of any symptoms. That is, there is no symptomatic UTI. You don't have to prevent symptomatic UTI by giving uroprophylaxis in antenatally detected hydronephrosis while the child is waiting for an MCU. But if the MCU is showing high-grade VUR, of course, we will be going for uroprophylaxis. Then what is the first-line antibiotic prophylaxis that is to be given in children older than 3 months? It is more than 3 months. It is quatrimoxazole or nitrofurantoin, again, to reduce the resistant strains. Previously, we were all giving cephalexin. Cephalexin can be given below 3 months. And then when will you discontinue the antibiotic prophylaxis? So that is if the child is at 2 years, then you have to look at 3 criteria. One is whether the baby is toilet trained. Older than 2 years, toilet trained, there is no bowel bladder dysfunction, and there is no febrile UTI in the preceding 1 year, you can actually think of discontinuing antibiotic prophylaxis. So then we have been bombarding on this bowel bladder dysfunction in recurrent UTI. So how to suspect bowel bladder dysfunction? So the child is presenting with recurrent episodes of UTI. Usually it will be a girl, and when you take the history, there will be history of constipation that will be there, and Bristol stool scale. You can all look at Bristol stool scale and see the pattern of stooling. The stool pattern will tell us that whether the child is constipated, and sometimes the child will be having impacted stools, and child will be also showing maneuvers to postpone voiding. These are called holding maneuvers. The pictures that are seen are Vincent's curtsy, that is squatting. Child will be, when the child is feeling like voiding, the baby will not be able to hold the urine and will become wet. So to prevent wetting, it will either cross both legs and then will be straining and the hand clenching will be there, or will sit with the heel pressing the perineum to prevent wetting. So these are the voiding maneuvers, holding maneuvers to prevent wetting. And the child may be having, will be a lazy bladder types, that is voiding less than 3 times, or child may be voiding more than 8 times a day. There may be straining and poor urinary stream. And when you do an ultrasound scan, you will be seeing that there is a bladder wall thickness. That is, in the distended state, it is more than 3 millimeter. And in the empty state, it is more than 5 millimeter. And post-void residual urine will be there, volume will be there. It is considered as significant if it is more than 10% of the total bladder volume. And the bladder volume at any age is age in years plus 1 ounce. So that means if the child is 10 years, 10 plus 1 ounce is 30 ml. So it will be 330 ml. So anything between 300 to 350 ml is considered as normal bladder volume in the child at 10 years, and more than 10% of the bladder volume, if it is there in the post-void state, it is considered as significant. And then persistent high-grade VUR. The VUR is not resolving beyond 3 years. Usually we say that primary VUR will be resolving by 3 years. But if it is persisting beyond 3 years, we have to think of bowel bladder dysfunction. And when we take an MCU, we can see the spinning top configuration of the bladder with bladder wall thickness, sometimes trabeculations. So the bowel bladder dysfunction is actually a problem which can lead to high bladder pressures, back pressure changes in the kidney, and chronic kidney disease. So to recapitulate, child with suspected UTI, urine dipstick is positive and culture is positive. Culture you will be doing. And so if the leukocyte esterase and nitrate are negative, but the risk factors were they are there and the age is less than 6 months, we may presumptively start an antibiotic and wait for the urine culture to come. If the child is more than 6 months and there are no risk factors, we can wait for culture, don't start antibiotic at that point. If the urine culture is positive, that is confirmed UTI, and we will be continuing the antibiotic for 7 to 10 days. And if the child is having this, an older child with confirmed UTI, always assess for bowel bladder dysfunction also. And we will be doing an ultrasound scan. If it is normal, you watch for recurrences. And if it is abnormal, we will be going for an MCU. And if it is a recurrent UTI, we will be going for an MCU. MCU if it is showing high-grade VUR, or if there are recurrent episodes of UTI, a late phase DMSS scan is to be done. Okay, so these are the important points that are to be, that is recapitulation again. MCU should be considered if there is a non-E. coli UTI, child is less than 2 months, and evidence of bowel bladder dysfunction is there. So finally, to conclude, UTI is a common bacterial infection and clinical diagnosis is unreliable. Urine sample is required for keeping the diagnosis, and urine culture is the gold standard. And dipstick is now a screening test for detecting the UTI, for screening test for UTI, and the prompt management should be started within 48 hours to prevent short-term morbidity like urosepsis and long-term morbidity such as renal scarring. And a small proportion of children with first UTI and no history of antenatal renal abnormalities may sometimes have clinically important anomalies. And so we have to be judiciously doing the follow-up investigations to pick up such children and treat them in time. And current recommendations encourage performing all those radiological investigations like MCU and DMSA scan, and only in children at risk, and discourage routine prophylactic antibiotic use. Routine renal ultrasound sonography should be done during the hospital stay in febrile infants and young children with UTI. And VCUG is not routine after the first febrile UTI. If the child is bigger and there is ultrasound is normal, we will not be going for a VCUG. And long-term antibiotics reduce the risk of recurrent symptomatic UTI in susceptible children, like children with BBD or children with recurrent UTI or children with high-grade VUR. And less aggressive imaging and judicious prophylaxis, use of prophylactic antibiotics in the era where antibiotic resistance is an emerging increasing challenge. And so we have to detect early, treat promptly, and follow-up also should be planned in such a way that we will not be over-investigating or under-diagnosing or over-diagnosing these children. Thank you.
Thank you, ma'am. Thank you, ma'am, for the wonderful talk. Can we take questions, ma'am?
Madam, you can stop share, ma'am.
Yeah, yes.
And we have some questions in the chat box. So the first question is, what about urine collected by the urine collection bag?
Urine collection bag, if it is growing no organism, that is, if it is sterile, then you can rely on it.
So it is more a negative predictive value than
Yeah.
a positive. What about storage of urine before culture and sensitivity and microscopy before being sent to the lab?
Yeah, actually, urinalysis, the theory is telling that it is actually 6 hours, you can refrigerate it and then do the investigation. But the problem is, you know, when you are suspecting UTI, it will be better to have a freshly voided sample that is analyzed and the freshly voided sample that is going for culture, that is within half an hour of the collection. If it is plated, that will be much better than having it stored.
When we do an ultrasound for something else, like an antenatally detected hydronephrosis, everything else is normal, like normal kidneys, but the bladder shows cystitis or echogenic particles, and a urine routine as well as a culture comes out normal. What does this mean?
Yeah, very common scenario. Maybe it's a concentrated urine, or it may be a urine that is, maybe crystals may be there in the urine. A very common scenario, you will be seeing that the urinalysis is totally normal. You can actually advise the child to take more fluid and also encourage frequent voiding.
Should all non-E. coli UTI is to be sent for VCUG?
All non-E. coli UTI,
Require VCUG or not?
yeah, the VCUG is actually recommended if the ultrasound is abnormal in an older child or a very young child, less than 2 years of age, the first episode of UTI, complicated UTI. So that is, again, this non-E. coli UTIs will be complicated UTIs. So such episodes, so it is actually the clinical situation that demands attention before you make a decision. And guideline is telling non-E. coli UTI, you have to do investigations, more investigative rather than them. And another important point that you can take is, if the response is not occurring within 48 hours, then of course, there could be a structural abnormality that is there. Do the ultrasound scan. If the ultrasound scan is normal, then you have to look at the age of the child and situation, whether it was complicated with AKI and all, and a non-response within 48 hours, then I think you can proceed with VCUG.
We have two related questions. How much is the risk of UTI in a child with tight phimosis?
Yeah. It again, the risk evaluation has not been really reported after phimosis, but we commonly see phimosis in a boy and the vulval synechia in a girl is actually risk factor for. And also this circumcision has been now recommended in the recent guidelines as a procedure to reduce the risk of UTI.
So that was the second question. If circumcision is useful, when to do it?
Yeah, it is less than 1 year. Less than 1 year, circumcision is considered beneficial.
If there is coexistent hypertension in UTI, what are the drugs which can be used?
Usually for renal hypertensions in pediatric age group, we will be the first line agent which we will be using is calcium channel blocker. You can use nifedipine if the BP is to be controlled fast, or if it can be gradually controlled, you can go for amlodipine.
Can we use fluoroquinolones for UTI if the culture and sensitivity is
so regarding the
favorable?
culture and sensitivity, one important point that is made in the current guideline is, you started an antibiotic. Within 48 hours, you are having a response, clinical response is there. But when the culture came, that antibiotic is reported as resistant. But the current guideline is to continue the same antibiotic which you are giving and not to change the antibiotic, because the patient has started responding to the antibiotic. And also the current guideline is not recommending a repeat urine culture after completing the treatment. Repeat urine culture we will be doing if the patient is not responding within the first 48 hours of therapy. So the question is fluoroquinolones, actually it is considered as a reserve drug in the pediatric age group. We usually will not take and use fluoroquinolones considering that reported the cartilage impact and all. We are not regularly using fluoroquinolones, but definitely in an older child, if the fluoroquinolone is to be used and it is the antibiotic that is sensitive and the child is not responding to the other antibiotic, then of course we will give.
Can we use nitrofurantoin for UTI treatment?
For urinary tract infection in children, the one dictum is that, especially if the child is small, it is considered, and high fever was there, it is pyelonephritis. So for treating pyelonephritis, you need to have a good concentration of the antibiotic in the renal parenchyma. The problem with nitrofurantoin, nalidixic acid, and norfloxacin is that these three antibiotics are not properly getting a proper, means not getting concentrated in the renal parenchyma for a bactericidal effect. So these three antibiotics are not used in treating febrile UTI in children. And the febrile UTI is equated as pyelonephritis.
When to advise circumcision in a child with phimosis?
So that is actually a question for pediatric surgeon. Phimosis is physiological till 2 years. And there is some hormonal imbalance that is underlying the phimosis or tight phimosis, tight foreskin. If there is ballooning of prepuce and there is UTI and all, possibly there is an indication to do correction of phimosis at an younger age. But usually I think it is beyond 2 years only considered as an indication for circumcision.
Madam, you told before about some 1 year cutoff regarding phimosis.
1 year is this if doing circumcision and not doing circumcision, a protective impact on the means protection from UTI in studies is only in babies who are below 1 year.
That is without phimosis.
Yeah.
Okay. That is just by doing circumcision.
Just by doing circumcision, reduced risk of UTI documented by studies only below 1 year.
Okay.
How common is UTI in normal term neonates in the absence of Kakut?
Normal term neonates UTI is in newborn. Actually, urinary tract infection is considered as not due to ascending infection but a hematogenous infection. So renal, PUV is one Kakut which will be presenting very commonly in boys at birth with urosepsis. Other than that, if a normal urinary tract is there, UTI may not be there in a neonate. Actually, we are having lot of protective mechanisms inherent in our urinary system to prevent bacteria from entering and multiplying. So only if that is breached, we will be developing UTI, especially so in the newborn infants.
Should urine routine be done in all cases of fever in a newborn?
Yeah, if you are not having a focus that is identified, especially late neonatal sepsis, urinalysis is important. And when the focus is not there, if you are having a focus identified, then you don't look at the urinary system. Otherwise, definitely any fever without a focus, urine has to be looked at.
In a child with symptoms of urinary tract infection who already received antibiotic from outside, should we still send urine for culture and sensitivity?
Once again, please repeat that question.
There's a child with symptoms of UTI. He's already received 1 or 2 doses of antibiotics from elsewhere and now comes to you. Will you send a urine culture again?
Yeah, see, the thing is that child is having symptoms of UTI. Child has received antibiotics from outside, but still the child is febrile. So definitely I will be sending a urine analysis and urine culture.
So what could be the cause for a 12-year-old girl to have recurrent UTI in spite of having a normal ultrasound and no bowel bladder dysfunction?
See, the cystitis urethritis complex is very common in the adolescent girls. This is secondary to the poor perineal hygiene. And so that is common. We have to advise them regarding the perineal hygiene, proper urination technique that is to be advised. There is something called vaginal voiding that is there. That is if the girl is sitting with her legs not spread properly, part of the urine can go into the vagina. And once the child gets up, it can soil. And always we have to understand that urine is sterile when it is passed. but it has got all factors that are there for a good bacterial growth. And so there will be bacterial growth, and the child is at risk, or girl is at risk of cystitis urethritis, especially urethritis. Urethritis is very common, and this is secondary to the poor perineal hygiene. And another thing is younger school-going children, girls, even this enterobius vermicularis can be a cause for acute urethritis. The child will be passing urine with lot of difficulty, and lot of pain and burning sensation will be there, but no fever. And if you do urinalysis, you may get pyuria. If you do culture, you will be growing something, but the child is afebrile, the kidneys are totally normal. Doing an ultrasound scan, most often the bladder is also reportedly normal. But if you do a local examination, you will see that lot of excoriations and erythema and the inflammation will be there in that local area. So these things we have to look at.
Can MCU be done in an acute infection?
MCU is not done during the time of acute infection. Only after the infection is completely cleared, then only you have to plan the MCU. And before you proceed with any instrumentation of the urinary system, you have to document a sterile culture, and you will be doing an MCU under antibiotic cover.
What is the significance of asymptomatic bacteriuria in a child?
Asymptomatic bacteriuria is actually, that was what I was telling, no, just doing without symptoms, doing a urinalysis and urine culture is to be curbed. It is not a good practice. And asymptomatic bacteriuria doesn't require any antibiotic therapy.
And what would be the prophylaxis duration in bowel bladder dysfunction?
That is actually not addressed properly. Once the bowel bladder dysfunction is treated properly, cleared, and child is better, and then you can think of stopping the antibiotic if the child is completely free of symptoms, as well as UTI episodes doesn't occur in 1 year, then you can think of stopping prophylaxis.
Many guidelines advise oral antibiotics for pyelonephritis, but do we really practice it?
So it depends on the clinical situation. Depends on the clinical situation. If the child is not toxic, not having AKI, good amount of urine output is there, and you're sure that the child will take the antibiotic, you can try giving oral antibiotics for acute pyelonephritis. But if the child is less than 2 months, toxic, persistent vomiting, so most often the acute pyelonephritis that we see in our clinical practices, children will be febrile, toxic, vomiting, abdominal pain. They are not able to, high temperature, 103 degree and all. So I will not venture giving oral antibiotic in such a situation.
If a child on UTI prophylaxis develops a breakthrough UTI, how would you manage it?
So breakthrough UTI, you have to treat the antibiotics depending on the culture and sensitivity, and you have to treat that properly, then reassess the child for the presence of any other evolution of more problems, like the child may be having more bowel bladder dysfunction evolving. Though such things have to be addressed, and you can continue uroprophylaxis.
So which antibiotic would you use to treat? Suppose the patient was on Fexin prophylaxis or Septran prophylaxis, which antibiotic would you start empirically?
And then immediately you can give this third generation, if it is a pyelonephritis, third generation cephalosporin or amoxiclav is the guideline recommendation now. And after you treat the infection properly, you can go back to either quatrimoxazole or nitrofurantoid.
Is there any role for probiotics?
Yeah, cranberry juice is actually considered recommended in the current guideline as one factor that can actually prevent episodes of UTI.
If bacteria is present in urine, but no pyuria, is it significant?
Yeah, that is very, very pertinent question that is put forth. See, the thing is that if bacteria is invading you, you will be mounting an immune response. And so that immune response will be manifested by presence of WBCs in urine. Pus cells will be there in urine. If you are immunocompromised, there may not be, an immunocompromised host may not have pyuria. But keeping this in mind, the current guideline is telling that if leukocyte esterase is positive, nitrite is positive, and there is no leukocyturia, you cannot rule out UTI. You have to still send a urine culture. I am actually not very that sort of a thought process or a concept, I am also not ready to accept. But still, that is the guideline.
If the urine microscopy shows plenty of puzzles, but the culture comes negative, but you have started antibiotics, but fever still persists, and the repeat urine microscopy again shows plenty of puzzles, what to do and how to proceed, because the culture came as negative.
Yeah, apart from bacteria, other organisms like viruses also can cause urinary tract infection. That is one thought process that is there. Second is fungal UTI that is to be thought of if the patient is still having fever. And then partially treated bacteria means UTI, then there may not be any culture that is positive, but still there may be some organism that is there. And then tuberculosis of the urinary system, very, very uncommon in children, also to be thought of. So L forms. So we learn like that, no? The sterile pyuria. But the sterile pyuria without bacteriuria, sterile pyuria without fever can be secondary to the crystalluria. That is also to be thought of. But this index child is, if child is febrile, then definitely I will send the culture and change the antibiotic and see the situation. I will look for whether there are some fungal hyphae, budding yeast forms in the urine. That is one thing. Then another thing is viral cystitis. But viral cystitis, usually fever may not be a very great problem. May be having a lot of irritative voiding symptoms. And adenovirus cystitis can be associated with a lot of hematuria and pyuria.
There's a 1 month old treated for UTI. Should we give prophylaxis till MCU and DMSA is complete?
1 month old baby with febrile UTI. 1 month old baby.
1 month old with febrile UTI who has been treated should the child be on prophylaxis till MCU and DMSA? That is the old guideline.
Yeah, I will give. But the guideline is not recommending. Guideline is to guide you, not to you need not follow the guideline dogmatically. You have to use the clinical sense, and sometimes you may deviate, no?
Is dipstick commonly done in our community?
In our doctor community, we don't routinely, but I think we have to start accepting. All private hospitals are doing dipstick. I don't think in SAT we are doing dipstick. Yeah.
And neonatal UTI, how should they undergo imaging?
Yeah, of course, ultrasound scan is to be done in all babies with UTI.
And should we do a repeat culture before planning an MCU?
Yeah, that is because your instrumentation of the urinary tract, you have to document that everything is okay, sterile.
Why is bacteria coming positive in majority of samples from labs when the puzzles are less than 5?
Bacteria is there everywhere in the environment. That is
especially if they look at the urine a little later, they keep it for a few hours, then bacterial growth can happen.
It can get, and bacteria may be multiplying. Puzzles may be degenerating.
We have a few more questions basically on CACUT and antenatal hydronephrosis. Since it's not related to this topic and this itself is a huge topic, I'm not taking up those questions. I would like to invite everyone to our NephroCon in June, where all these topics would be discussed in detail.
Where is NephroCon? That also you should say.
It's in Palakkad on June 15th.
Okay.
If we have any questions from the audience,
you can also plan 1 or 2 webinars also after a few months, because the attendance was very good, almost 100. It was full. Okay.
Yes, sir. People were not able to get in actually.
Yeah, because it is there in the YouTube also. We can see it again also. It will be there in the IAP website, IAP Kerala website.
And there's a couple of questions. IV antibiotics before MCU.
No, we don't give IV antibiotics regularly before MCU. We will be giving oral antibiotics for prophylaxis. One dictum that is followed by our pediatric surgeons is to give the cephalexin morning, noon, and evening on the before the day and on the day and the next day. We will be giving usually 3rd generation cephalosporin, cefixime, morning and evening, starting 1 day prior, continue on the day, and then the next day. So 3 days. So, but if it is an emergency, like the MCU, they have forgotten or they have not taken, sometimes, very rarely, that is a rarity. It is not a guideline. You can give one shot of amikacin 1 hour before the procedure. That is also okay, but it is invasive. It is like giving an injection to a child who is otherwise normal. So, not to be encouraged.
Someone has asked the formula for calculating residual urine. That's age plus 1 into 30, the bladder capacity.
So if there are no more questions, so it was a lot of questions. It was like I was giving a viva.
So I think we took the right topic for discussion today because this is something
because
everybody
urinary
has a lot
tract
of queries on.
Yes, urinary tract infection is always like that. Purushottam sir ഉണ്ട് സാർ എന്തെങ്കിലും കമന്റ്സ് ഉണ്ടോ സാർ?
It is an excellent the topic covered by Susan, Adarshna, Radhika, and Christy. A few comments, Susan. Febrile UTI, the Mosclav, amoxicillin, clavulanic acid, and cefixime. In fact, majority are gram-negative. If you are given an option, Mosclav or cefixime, cefixime will be better opting opt for that. So why that guideline for amoxicillin in that situation?
Yeah, actually, third generation cephalosporin or amoxiclavulanic acid is what is given. So you can actually, like amoxiclav, if you use, you have to see more GI side effects are there. We all are more comfortable using third generation cephalosporin rather than amoxiclav.
Because at the organism, considering the organism spectrum, amoxicillin clavulanic acid covers more of the gram-positive, and the contribution by the gram properties is less. It also covers the gram-negative. That's all.
Gram-negative is also covered. It is broad spectrum. But cefixime is what we are commonly using, and we all use cefotaxime when we are going for IV.
Complicated duty, of course, there is no doubt. About the view of the situation, then adolescent girl in the I think in the coming years, more of UTI, we should be stressing that's an IAP policy. The schools you should be providing safe water and encourage more water consumption.
Yeah, you're right.
The constipation prevention, encourage the vegetables, fruits consumption, not only for weight reduction but for prevention of the UTI. And in the evaluation part, adolescent, we have seen a few cases of pure gynecological problems mistaken for UTI. One is the hematocolpos because of the hymen, imperforate hymen presenting periodically with the pain, and in between they will be all right, so we'll be missing it. And another thing is the ovarian cyst torsion. It is usually on the side pain, but it will displace over to the midline and a little constant pain. So it can be taken as a cystitis. So in the evaluation, always see the lower abdomen for a mass, evaluate the perianal area for some scars and history of the surgical intervention. In the neurological evaluation, ankle jerk and the caudal sensations and the reflex, the glands, the perianal reflex and the sphincter, this tone. Those evaluations are needed for all adolescent girls. And you rightly point out the need for the local examination about the 3 points, the congestion. This worm is very important because we are encouraging 6-monthly albendazole for the program, but that will not take care of this worm unless the whole family is treated. So there is very high chance of this endobius producing this sort of urinary thing, especially in a girl child where the menstrual hygiene duration during those period and all, the possibility of fungal infection also. So fungal infection, the worm problems, and the hymen. So unless it is looked for, you may miss it.
Yeah.
So in the school, the thing we need to include in the teaching the encouragement of the water, prevention of the constipation, and the girl doctors should be looking at the genitals in a girl, adolescent child. One more thing I wanted to tell. Then the PGs. So our PGs nowadays, we were all doing the bedside examination. What's happening in the new era, in the new PG teaching is they are just ticking a list of investigation. They are getting the answers and they are entering in the case sheet. Nobody is comfortable with any of the finding because it's a liquid biopsy. Urine microscopy, nobody is doing. No identification of pus cells or crystals or the cast. So how can you encourage them to do this thing? It should be the mandatory only. So Riaz, we think about them including one station in the OSCE, whether you can include a microscopy of a few of the bedside thing, like HUS periparal smear, malarial parasite, urine cast. So we should be seriously considering that our postgraduates are not doing it. Somehow they should be encouraged. That big thing is because in the private institutions, all the investigations are done and they are not entering into the lab. Previously, we were doing many of the investigations, CSF cytology, urine cytology, nothing is done by the postgraduates. So that was an excellent experience, Susan.
Thank you, sir. You are
Thank
very true in pointing out this impertinent clinical examination, which is to be followed, as well as the means the microscopic assessment evaluation. We were having all side labs where the microscope was kept, centrifuge was there. These things are missing now. Yeah.
Thank you,
Susan,
sir.
I am Ashok Kumar.
Yeah, sir.
Yes, sir, please.
A long time, for 40 years, I have been asking for guidelines for MCU. And I always thought we were overdoing it because an invasive procedure, I've actually thought of, I would say, Balapidha. We are raping the child, actually holding the penis, and not only that, irradiation, and too much irradiation. So I have been trying, and I am happy that finally the pediatric nephrologists have come down on the indications for MCU in urinary tract infection and complicated urinary tract infection. Previous, when I was a PG or young tutor, all the pediatric surgeons said that every case you do a MCU, every case you do MCU. But that I was against. But I am happy that the guidelines finally has become a little relaxed.
Another investigation that has to go down is IVU, sir, in children. IVP, that also has to go.
Susan, any requirement or how much water you think a baby or a child should drink?
It is ad libitum, sir.
Ad libitum,
Yeah.
not forcibly
No, not forcibly. It is the child should have access to water.
Our parents' fault that they are not making the child drink. Child will drink only if the child is thirsty. But parents are advised to give water plenty, make the child drink water like that. It's your fault that the child got UTI and all those things.
The thing is that children should have access to water. So small baby, we have to give. We have to offer. And also look at the urine color. And if the urine color is deep yellow, you know that the child is not getting enough water. The stool that is hard is another factor that will be thrilling. Most often the child will show the thirst and ask for water. So it is ad libitum.
One more thing, to get a urine sample is very difficult nowadays because everybody is using a diaper. And I always say to do an CSF, lumbar puncture and get CSF is easier than getting a urine specimen because child is in a diaper all the time. And, it's very difficult. And even this thing, post-urethral valve, we always ask mothers, how is the urine stream? I said, we have never seen urine stream. Child is always in the diaper. We have never seen the urine stream. So probably we are missing a number of post-urethral valve.
Yeah. But antenatal scans have actually picking up lot of these problems, sir. And another thing is actually some of these things we have to go back a bit, having the diaper all the time. And in the usually I have seen my grandmother when my cousins were born, keeping them, taking them and just switching on the tap. And when the water is flowing with that sound, the baby will be held and the baby will be with in the hands and the baby will be passing urine. So I have seen that so many times and I have also followed that for my kids. So seeing the urine stream is not difficult. Only thing is nowadays we are not having the time. People are all running. So they have shortcuts.
I was, when I was doing senior house agency in CMC Vellore, we were asked to collect urine ourselves, go to the lab and plate the urine immediately. We were given the key to the microbiology lab. So we used to do that. But to get the urine specimen, we have to coax the child. മോനെ കുറച്ച് മൂത്രം താടാ മോനെ കുറച്ച് മൂത്രം താടാ പറഞ്ഞിട്ട് എത്ര നേരം അവന്റെ മുമ്പിലേക്ക് കുത്തിയിരുന്നിട്ട് കുപ്പി പിടിച്ചോണ്ടിരിക്കണം. എത്ര പ്രാവശ്യം പറഞ്ഞാൽ അവനൊരു അല്പം മൂത്രം ദയവോടെ തരുന്നത്.
Susan, Sir പറഞ്ഞു കഴിഞ്ഞോ? Sorry.
കഴിഞ്ഞു.
Susan, Radhika or Christy, I have a request because we have got a social media video being prepared by our team, IAP team. There are few points which if you make a video, that will be very useful. One thing is that perineal hygiene part, and especially during the menstruation and adolescence, and how to guide the kids, adolescent kids by the mothers about the cleaning and the prevention of the constipation and the chances of the worm trouble and all. Small videos, maybe 2 minutes. You can take a better video, include the contents are more important. And that will be very useful because you are experts and your words will be given value by the mothers. Then Riya sir, we should be reviving the school part.
Yeah.
And they encourage the parents to participate in the discussion. We should be visiting the toilets of, especially of the girls, during the monthly meet.
Sir, actually, we have already prepared one letter to both the government as well as the school management association. So where we have made a checklist of the toilets so that there should be someone to check the toilets. Like we are telling that students should drink enough water at school. But the problem is the toilets are not at all usable. That is the problem. They are not drinking. So that is a very important point that we can tell, ma'am. And these videos, I think we can take in our own studio at SAT and please send it to me. So we will upload it in the social media. That we can.
Yes. I request Dr. Gobi Mohan to say a few words.
Gobi, ആദ്യം കണ്ടില്ല ഗോപിയെ.
Dr. Gobiക്ക് കേറാൻ പറ്റിയില്ല.
Okay.
Dr. Gobi?
Practicing ആയിരിക്കും Gobi.
Gobi hospital ആയിരുന്നു ഇന്ന്.
He joined, I think he again left.
Okay.
I request Dr. Manjusha, Secretary, Nephrology Chapter, to deliver the vote of thanks.
Thank you, dear Susan ma'am, for the very informative talk on UTI. It was so nice listening to you as always. Thank you, Riya sir, President IAP Kerala, and Dr. Gobi Mohan sir, Secretary IAP Kerala, for encouraging us to conduct this webinar. And I thank all the seniors, colleagues and friends for the enthusiastic participation in this webinar and making it a success. It was so nice to see so many people for the webinar. Thank you all.
മഞ്ജുഷേനെ ഞാൻ ആദ്യമായിട്ട് കാണും തോന്നുന്നു. മഞ്ജുഷേനെ അധികം പരിചയമില്ല എനിക്ക് എന്ന് പറയാം.
വീഡിയോ ഓൺ ചെയ്യാമോ?
സാർ വീഡിയോ ഓൺ ചെയ്യും സാർ, പക്ഷെ എന്തോ ഒരു കാരണം കൊണ്ടോ അത് ഒന്നും കാണുന്നില്ല സാർ.
Okay. Next time. Okay.
ഞാൻ കോഴിക്കോടാണ് പഠിച്ചത് സാർ. ഐ തിങ്ക് വി വിൽ മീറ്റ് ഡ്യൂറിംഗ് ദ IMCH അലുമിനി മീറ്റ്.
10th ഉണ്ടാവും.
Yes sir, we'll see there sir.
Okay. Thank you
Thank you.
for this.
Good night.
Thank you. Good night. Gopi has come. Gopi, കേൾക്കാമോ? Okay, Gopi can no problem. Okay, so we will close. We will close for you. Thank you. Good night.
Good night.
Night.